Good afternoon once again to all of us. My name is Dominic Akaateba, and I'm with Ghana Medical Health. This afternoon, on our maternity service agenda, we are looking at primary postpartum hemorrhage. This is an important topic. I'm sure most of the midwives and doctors in obstetrics and gynecology would agree with me that this is the commonest thing that is mostly encountered in our various maternity wards, our health centers, district hospitals, and in the CHIPS compounds as well. So we are honored to be having Dr. Dieu-Donnee, who is a resident at the Tamale Teaching Hospital at the Obstetrics and Gynecology Department, with supervisor being Dr. Hawa, Malechi, who is a consultant gynecologist, leading us this afternoon on a presentation to help us with the basis of primary postpartum hemorrhage. A couple of things, I would be muting everyone. Just like you can see, there's a bit of distraction from participants. So right after the introduction and when the presenter starts, you notice that you'll be unable to unmute yourself. However, the chat box would be available so that then you can use that and throughout the presentation, just in case you have a question that you can't wait until after the presentation. So just about that, I've done that. I've muted everyone. You notice that when you try to unmute, you'll be unable to. However, the chat box is available. Kindly make use of it throughout the presentation. But at the end of the presentation, which you are hoping to have it done in 45 minutes, we'll have about 15 minutes of questions, comments, suggestions for making this presentation an excellent one. And remember that every week on Thursday and Friday, we have these very simple, very common medical topics, and Friday specifically for maternity, topics related to maternity service delivery. So kindly make a date with us. It's the same link, the same login details, the same password, the same link every Friday, Thursday, 3 p.m. to 4 p.m. Without much ado, kindly help me welcome Dr. Hawa, who would introduce the team, and then they can start. Thank you so much. Dr. Hawa, over to you.
Thank you so much. Good afternoon to everybody, and Happy New Year to us all. Postpartum hemorrhage is a big thing for us as managers of women in labor and delivery. And I'm happy that we are opening this year with this topic because there is a lot we can do to reduce the numbers that we record that end up as mortality. Postpartum hemorrhage is still the #1 cause of maternal death. And there is so much that we can do that can change the narrative. Today, Dr. Donnee is going to remind us of the facts that we know already and also sharpen our minds on the things that we do that we can change to make the outcome better for women who deliver with us. So we are all welcome to this afternoon's presentation. Let's stay on to the end and let's have a fruitful discussion. Donnee, over to you. Thank you. It looks like we can't hear Donnee.
Yeah, kindly unmute yourself. I suspect she forgot to unmute herself. Hi, Dr. Donnee, can you hear us?
Yes, please.
Okay, great. Yeah, so we can hear you now. So you could probably start. Thank you.
Okay. All right. Thank you. Thank you for the opportunity. So I'm presenting on primary postpartum hemorrhage. Dr. Hawa Malechi is my supervisor. So like she already said, postpartum hemorrhage is one of a major concern to the world at large because it affects women of all ages and of all tribes and descent, and is a major cause of maternal mortality all around the world. So this presentation seeks to help us to be able to promptly recognize some of the risk factors, to be able to know how to appropriately manage these women and prevent complications that arise from this obstetric hemorrhage. So this will be the outline of my presentation. So it's an obstetric emergency that complicates about 1 to 10% of all deliveries, and is the leading cause of obstetric maternal death. About 25% of all maternal death arise from primary postpartum hemorrhage, in general, and especially in the low-income countries. About 80,000 maternal deaths are due to PPH worldwide. The highest incidence is recorded in Africa, followed by North America and Asia. So in 2008, the government of Ghana declared the maternal mortality as a national emergency due to high rates of maternal death that were recorded specifically in the northern region, and PPH was noted to be the major cause. So in Ghana, generally, we have about 60% of maternal death, which is caused by PPH in Kolebu. A study was done in between 2015 and 2019, and the prevalence was 20.6. In Tamale Teaching Hospital, postpartum hemorrhage contributed to 3.5 of maternal death in 2022 and 14% in 2023. So WHO has made a few efforts so far with respect to the postpartum hemorrhage. They've developed a lot of roadmaps. They've reviewed what has been done in the past, which we'll be looking at in the new management protocol. And due to that, they've been able to come up with a few guidelines for some of the primary postpartum hemorrhage and the complications that can arise from it. There's still a lot of research and data that is ongoing to find out why, even though it's some of the management protocols are easy, the medications, the fluid resuscitation are easy to come by, but we still have very high maternal records from maternal mortality. So to define it, it can be defined basically as any bleeding after delivery in excess of 500 mils if it's via the vaginal route, and more than 1,000 mils if it's via cesarean section. In 2017, the American College tried to, redefine it, and then it said that sometimes because of problems with quantifying the blood loss, in addition to just using the amount of blood loss, you can also add if the woman has any signs and symptoms of hemodynamic instability, she comes with symptoms of hypovolemia, is enough to make diagnosis, or any amount of blood loss that can warrant blood transfusion is also enough to make a diagnosis of postpartum hemorrhage. And then also if you have hematocrit of greater than 10%, because sometimes because of the acute blood loss, the woman's initial hemoglobin will not be a good assessment to say that she's lost enough blood, but at least you can use the hematocrit drop of more than 10% to make that diagnosis. The Royal College also of Obstetrician and Gynecology sought to divide it into either minor or major. So a minor PPH is between 500 and 1,000 mils of blood loss. If it's major, it's more than 1,000 mils. There are other definitions when during hysterectomy, when you have more than 1,004 mils for an elective hysterectomy, cesarean hysterectomy, more than 3,000 mils. If it's an emergency, there's a mistake there. So if it's more than 3,000 an emergency cesarean section, you can define it as postpartum hemorrhage. And then, so today I'm discussing, we are talking about the primary postpartum hemorrhage, but you can have it as a secondary postpartum hemorrhage when you have the bleeding occurring for more than 24 hours to 6 weeks postpartum. The Royal College says you can go up to about 12 weeks postpartum. The causes of primary postpartum hemorrhage can be grouped into four. The 4 T's plus uterine inversion. So the T's: tone, trauma, tissue, and then thrombin. The number one cause is from tone, and tone is as a result of uterine atony, which account for about 80, some say 70% of the cause of primary postpartum hemorrhage. Trauma makes up about 10 to 15%. That's from lacerations, genital lacerations from the vagina, vulva, vagina, cervix, and then uterus as well. And then tissue thrombin, that's if there's any bleeding problem. So let's look at the different categories. So with the tone, the first T, anything that would result in the uterus being over-distended to a point that the uterus cannot contract, because contraction of the smooth muscles of the myometrium is the major mechanism that helps with reducing blood loss post-delivery. So if you have anything that would stretch the uterus to the point that its normal contracting mechanism will be affected, then you would have atony. So from over-distension, from multiple gestation, uterine fibroids, prolonged labor, grand multiparity, and then also placenta previa, low-lying placenta that could also affect the uterus's ability to contract, because once you have the placenta at the lower uterine segment, it interrupts with the uterus's natural mechanism of contraction. Placenta abruptio would sometimes lead to covally sipping of the blood into the myometrium and cause disruption in the contractility of the uterus. Retained product, of course, would hinder the uterus from contracting as it should. Halogenated anesthetic agents, such as some of the anesthesia that is given during general anesthesia, like isoflurane, etc., have an direct effect on the contraction of the uterus. They make the myometrial muscles relax, so they can also be a cause of primary postpartum hemorrhage. Lacerations or trauma from instrumental delivery of a big baby, intrauterine manipulations in retained there's a non-cephalic second twin that you have to do maneuvers like internal podalic version, sometimes even external cephalic version, precipitous labor, uterine rupture from previous cesarean section, hyperstimulated uterus from syntocinon augmentation, and so on. The third T, retained placenta. If you have a morbidly adherent placenta, the placenta goes into the uterus, into the myometrium, and sometimes can even extend outside of the uterus to other surrounding organs. They can all cause primary postpartum hemorrhage. If you have an accessory lobe from a subcentrate lobe of the placenta, you can have it retained and then subsequently cause bleeding. Thrombin from either if it is acquired or congenital. So acquired can be from bleeding, excessive bleeding that can result in consumptive coagulopathy from placenta abruptio, sepsis. And then you can have IUFD that can also result in DIC. from amniotic fluid embolism, and people with congenital bleeding disorders such as hemophilia, Christmas disease, von Willebrand, etc. So the physiological changes, there are some physiological changes that already occur during pregnancy, and there's already an increase blood volume of about 45%. You also have the increased maternal blood volume is usually about 45% in general. And then you have about plasma volume also increasing to about 30 to 35%. You have also increased red blood cells. So all these, and pregnancy itself is a hypercoagulable state. So all these mechanisms, all these natural physiological changes in pregnancy would warrant blood loss if there is no mechanism that puts in a check so that there will be no excessive blood loss when the baby is delivered. Apart from that, there are some structural changes that already occur. There is hyperplasia and hypertrophy of the uterine muscles, and all that can contribute in the over-distension of the uterus as well. I think I already mentioned that excessive bleeding is usually prevented or is controlled by the myometrium. The myometrium has 3 layers. The smooth muscle has 3 layers. The middle layer is usually arranged in a crisscross cross fraction, which are able to, during contraction, it's contract and relaxes. Instead of the relaxation, it retracts, it pulls and shortens. And by so doing, it compresses on the blood vessels. And that middle layer too has a lot of blood vessels. So all the blood vessels that are exposed, the bare area when the placenta is removed, by that mechanism, it's called the leaving ligature, is able to compress on the blood vessels and naturally stops bleeding from occurring. Platelets, factors that also release during the coagulation cascade in a case of bleeding or when the baby is delivered, also helps with the normal mechanism. In addition to myotamponade, so the anterior and abdominal wall, they're able to oppose each other. When they contract and oppose each other, they form a tamponade, a temporary tamponade, and that helps to control bleeding as well. How would we identify if someone presents with primary postpartum hemorrhage? Usually they would present with profuse bleeding per vaginal, and they would, if it's not profuse bleeding, it can even be scanty sometimes depending on the cause, because sometimes they can be bleeding intraperitoneally, but they can also, if it's quite severe or moderate to severe, they can present with signs and symptoms of blood loss. So based on the clinical findings in terms of checking the vital signs, you would see, or they can be anemic, they can look dehydrated, and all that. They can have cold, clammy extremities, tachycardia, all that. When you examine abdominally too, the uterus may be flabby because it's not well contracted, or sometimes if they are retained product, it looks flabby, very relaxed. The uterus may be tender or not. Sometimes if you have a uterine rupture or you have a retained product, and even just the normal contraction of the uterus may present with some tenderness. There can be some abdominal distension if there is hemoperitoneum, or sometimes suprapubic distension if the bladder is distended. That is one of the things that would make you, even give you a sign that maybe your bladder distension is what is preventing the uterus from contracting normally. Clinically, when a patient presents to you, you would have to assess them, do a general primary survey, airway, check their airway. So it depends on how they present with, if they are from a referral facility or you just, they come and you have to attend to them, you would have to assess their airway. If there are any secretions, you suction. The breathing, you check if it's spontaneous or not. The respiratory rate, you need to check the respiratory rate. And then the circulation, the blood pressure, the SpO2, if they would need oxygenation. Physical examination is very important in being able to identify the cause of the PPH. Like I mentioned, the #1 cause is from A20. So doing a comprehensive physical examination would help you. in addition to already having the history, because you also need the history from either the relatives or from the referral midwife or whoever brought them. So physical examination, from general physical examination, how they look, whether they look hemodynamically unstable, dehydrated, bleeding, obvious bleeding. Then you have to check for pallor, hydration, you check for signs of anemia. And then you can now go to the abdomen, which is of much importance. Like I already mentioned, you assess to see whether the uterus is contracted or not, whether there's tenderness, whether the abdomen is distended. And then you check for the other systems, the chest and all that, because in most of some of these cases, you can have multi-organ compromise. So you need to have a thorough physical examination of the patient. There's this shock index tool that can be used to assess patients. And even more importantly, sometimes if you are in a referring facility that you want to determine whether this patient needs a tertiary care or a higher institutional care, it's usually measured by dividing the heart rate over the systolic blood pressure. So it's an index of the heart rate over the systolic blood pressure. And it can be able to predict whether PPH is going to lead to some complications or is going to progressively worsen or not, or whether it's even improving. So if you have a score of more than 0.9, it's usually associated with increased mortality. If the normal range, the normal score is usually between 0.7 and 0.9. So if you have a score of 0.9, means that you are lateralizing towards 1. Lateralizing towards 1 means that you are going to have a heart rate higher and then a lower blood pressure, meaning that the patient is being decompensated. So the symptoms are worsening and the disease is progressing. Like I already mentioned, when you have a score of 0.1, so if a patient comes to you, you can just use the heart rate and the systolic blood pressure to find the shock index. If you have a shock index more than 0.9, you can, and you are in a referring facility, you can now think of a need for urgent transfer. There are a lot of issues with assessing blood loss after delivery, and that has been one of the major challenges in sometimes promptly recognizing the postpartum hemorrhage and treating it appropriately. So the reason is that it's difficult to assess blood loss after delivery because it's mostly by visual assessments, and we are all very different. And what somebody sees at 200 mils, the other person who sees it would think that is 300 or 400 mils. And so because of that, it really interrupts with how we sometimes are able to pick up a PPH and manage appropriately. Also because the clinical picture of PPH can manifest quite late. So it's important that there is a way to visually assess postpartum hemorrhage, so that we don't wait till the signs, because once the signs set in, it means that the patient is going into complications, and you don't want that to happen. So this is an old way of assessing blood loss, which, some of us use sometimes. We use the pad based on whether it's mild, moderate, or severe. I'll share the slide so we can see later. Either you use the pad or you use gauze that is soaked, or sometimes you use pants that are not calibrated, or based on if you have a D-wrap or a mat, or whether the blood spilled on the floor, you can use it to assess blood loss. It's said that this type of assessment usually underestimates the blood loss to up to about 50%. Still with the assessment of blood loss, based on your assessment, look at what WHO is doing now a bit later. But if we are going to still use what we do based on using the pad or whether the blood spilled and estimating, there are degrees of shock that we can look at. So usually when the patient, you estimate the blood loss and you have blood loss of about 500 to 1 liter, which is about a loss of 10 to 15% of the patient's total blood volume. there's a compensatory mechanism. So with that, the blood pressure is usually not affected. And the patient can have mild symptoms like palpitations and then dizziness and tachycardia. If it's mild shock, you have about 1 liter to 1.5 liters, and there's a slight decrease in the blood pressure. She can present with weakness, sweating, and then tachycardia. If it's moderate, 1.5 to 2 liters with marked blood pressure, should start becoming restless, significant pallor, and then oliguria. And if it's severe, you have about 2 to 3 liters loss. That's almost up to about 45%, almost 50% of the total blood loss of the woman. And she would have profound reduction in blood loss. And sometimes she can come unconscious, collapsed, or anuria. That's symptoms of acute kidney injury. How will we manage a patient who has primary postpartum hemorrhage? So the management is multidisciplinary, meaning that it is a teamwork. So from the senior most consultant to the house officer to the senior most midwife to the student to the orderly and even to the parents, the relatives of the client, we all need to come together to be able to manage the woman appropriately. The management principle seeks to correct the hypovolemia that it comes with, to be able to find the origin of the bleeding, and then to ensure that there is uterine contraction. Since A20 makes up about 70 to 80% of the postpartum hemorrhage. And then also sometimes if the non-surgical or conservative management fails, you have to perform surgery to be able to correct the PPH. So there's a mnemonic, Hemosoft, which has been used over the years to help us remember how to manage. H of the Hemosoft is help. Help is what I already mentioned, call for help, multidisciplinary team work. And the H can also stand for hands. So hands-on. You should have one person, one of the team members, hands on the fundus, gently massaging the uterus. A is to access. So the access is what I already spoke about, primary survey, assessing the patient physically, which would even include taking some brief history to know and ascertain what is happening and all that. In your assessment, you're going to resuscitate. So you pass 2 light bulb cannulae, and then you take samples for grouping and cross-matching, full blood count, blood urea and electrolytes, clotting profile, or a bedside clotting time, all in a means to help you to be able to start the initial management whilst you're still trying to figure out what might be the cause. And you need to establish the etiology. Establishment of etiology would start with history as well. To give there's retained placenta, you want to know whether the placenta that was removed was whole, or whether the woman has any bleeding problem from her history. So it means that you need to even assess her antenatally. You need to take her antenatal book, take history from the relatives, etc., and then physically examine her. If you would see any physical signs that would be suggestive in terms of abdominal examination, even perineal examination, to be able to ascertain what might be the cause. And then massage the uterus, which I already mentioned it in the help as well. Whilst doing all these things are done concurrently. Whilst doing all this, you would be giving your oxytocins, the uterotonics, via IV, usually initially by bolus IM, 10 international units, and then you would continue by giving IV in infusion. Sometimes if you don't have the oxytocin, which is quite commonly available, you can use ergometrin or some other ones like carbitocin if they're available. If your uterotonics do not work, I need to mention that this particular type of management is mainly for the A20 being a cause of it. You can, if you do, so by the time you're massaging the uterus and you're giving your uterotonics and all that, together with your assessment, you should have ruled out tissue being a factor. You should have ruled out maybe even trauma being a factor as well. Once you know that it's atony, then you can move ahead and continue the other management that will help stop the tonic uterus. So if after massaging, giving your uterotonics is not working, you shift to theater. Prior to shifting to theater, based on where you are, if you are from a referral facility, there are some things, some procedures or measures you can put in place to stop the bleeding temporarily whilst you move the patient to a place where the patient can get surgical management. I will talk about some of them later. So we have aortic pressure, we have anti-shock garment and bimanual compression or aortic compression. You can also, if it's atony, whilst you shift in theater, you can do pass a condom tamponade. After, of course, you have excluded tissue or trauma, and sometimes even infection if it's a secondary PPH. And then in theater, you can apply compression sutures, the B-Lynch braced sutures, and then there are other ones. If that is not working, you can move on to do pelvic devascularization. So you can ligate the uterine, ovarian, or the internal iliac arteries. And then if that is also not working, there can be interventional radiology than uterine artery embolization, which are, I mean, done in not where we are, of course. Or if this does not work, hysterectomy is like the, you know, last, what do you call it? Like hello to help stop the bleeding. So you can do either a sub or total hysterectomy. With respect to the fluid resuscitation, which is in the access, you can start the IV fluid. The principle is 3:1. So you give three times of per every 1 ml of blood loss. So if the patient loses 1 ml, you're going to give 3 ml of the fluid you're going to give. So you can either give a Ringer's lactate or normal saline to correct. It is said that after 3 liters of giving IV fluids, you need to of IV fluid resuscitation, you need to give blood, because you can't keep giving the IV fluids continuously like that because of the risk of fluid overload and the fact that you need red blood cells to help with the oxygenation proper. So you can, by then you would have taken your samples for group and cross matching. So after about you have resuscitated adequately, once you have blood available, even before you resuscitate 3 liters, you can give. But once you have given up to about 3 liters, you should give blood. And then you can give whole blood or a rhesus negative blood if the patient's blood group cannot be found. You can give FFPs, 12 to 15 mils per kg after you've given 4 units of blood. And the FFPs, you can give about 4 units. And it's advised to give calcium gluconate after about 5 units of blood transfusion. Platelet concentrates, if available for thrombocytopenia. You can also give a cryoprecipitate for hypofibrinogenemia. IV tranexamic acid is recommended to be given within 10 minutes and sometimes repeated after 30 minutes. It helps with the coagulation. It's an antifibrinolytic drug. Misoprostol, 600 to 800 micrograms can also be given, should also be given. So currently, the WHO has come up with what is called the emotive. So it was established in 2023. So in 2023, the WHO had an assessment of the postpartum hemorrhage management, and they tried to figure out why PPH still continues to be a problem and of global concern. And some of the challenges they found was that there was a lot of missed or delayed diagnosis. That was number one. They also found out there was delayed or missed treatment, and there was also delayed or missed identification of escalating or shifting to theater or having further management in case the initial management does not work. So because of that, they came up with the E motive, where the E stands for early detection of postpartum hemorrhage. The M stands for massaging of the uterus. O stands for oxytocic drugs. T, tranexamic acid. IV is IV fluid. And E is examination of the genital tract. So the E is examination of the genital tract, and the E is also escalation. And if the escalation does not work, you need to treat for refractory PPH. So what they said was that the E motive is not a new approach at all, and it's not like they are bringing anything new in the PPH management. All the E motive seeks to do is reinforce or make more comprehensive what is already in place for the management of PPH. So they came with the bundle approach. That's the motive. So the bundle is being able to do all that you need to do at the same time together, even when you see an improvement in the outcome. So you are going to give all these protocols, these management protocols, whether you see that the woman is improving or not, because they realize that the orthodox way of managing PPH, sometimes we're not able to achieve the result because we don't have a particular pattern. For example, some institutions give tranexamic acid, some do not give. Some give tranexamic acid on the order of a doctor or, so all of that affects the management. So it doesn't make it comprehensive. So that is actually the main purpose and the main reason why they came up with the E motive. And they said that you need to, the whole E motive is supposed to be done within a matter of about 15 minutes. So the early detection should be done within 5 minutes. So the early detection, the E motive is quite extensive. I'm trying to summarize it. The early detection, you are going to use a drape. Let me see. Okay. So you have these E motive drapes. So compared to our visual assessment, where we use either the pad or the floor or the non-calibrated pans, we are not able to really make a correct diagnosis of the amount of blood loss to ascertain whether it's PPH or not. So these drapes are provided in the E motive, where the drapes are calibrated. So the drapes, it can be seen here, but they have some markers where when you have a warning line, which is around 350 mils, and then you have an action line at 500 mils. And so you use that observation to be able to decide whether it's PPH or not. And so after you put the drape, whilst immediately the woman is about to deliver, you put the drape there. So after the delivery and she starts bleeding, you assess. Once you see blood loss of about 500 mils, you have to start triggering the E motive initiative. So if you have blood loss of about 500 mils, or you have 300 mils and any abnormal observation. So the patient has blood loss 300 mils, but she doesn't look hemodynamically stable. The amount of blood loss is not correlational with, you need to trigger the E motive. And with this, the other thing, so that is the E, the early detection. Then the massaging of the uterus too. They mentioned that it's something that has to be done consciously, because sometimes with the hemosalt, for example, the massaging is done or not done. But with the E motive, the woman has to be massaged gently and then reassess. So if you massage and then you notice that the uterus has contracted, you have to reassess in 10 minutes. So they even have a chart where you can chart whether contractions have occurred or not. And then you assess after 10 minutes as well to see if the contraction is sustained or not. And then the other thing is the oxytocin. So the oxytocin traditionally, we usually give about between 10 to 40 mils after we give the bolus in IV infusion to run sometimes for some minutes or for some hours, which is usually not very, well done, because sometimes it's run for very short or very long based on who is managing the patient. But the E-motive says that you would give the IV oxytocin, you would give 10 units in 500 mils of the crystalloids, and you would run it for 10 minutes. And then after that, you would give 20 minutes. Others say you give between 20 and 40 minutes for the next 4 hours. So it's very well structured. You know that the first 10 minutes you are running your 10 international units and 500 mils, and then the next 4 hours, you're going to run about between 20 to 40 international units in 1 liter of your crystalloids. And then tranexamic acid in the E-motive is given at all times, irrespective of whether it is an instruction or not. So if you are in a referral facility and you have tranexamic acid available, you give, and you can give 1 gram within 10 minutes. And then you can repeat. If the bleeding does not stop, you can repeat in 30 minutes. And then you need to examine the genital tract actively. You need to examine the for tears and then repair as you see, if that is the cause of it. If it does not work, then you escalate and then you move to the refractory PPH. So this is the response to the refractory PPH. If the PPH doesn't resolve with what you were doing initially at the labor ward or at the ER, you move to theater. Whilst moving, you move to theater to perform some of these I'm going to mention. But whilst you're going to theater, you can do a bimanual uterine compression where you place your non-dominant hand on the posterior aspect of the fundus of the uterus, and then you have your dominant hand inside the vagina, usually at the posterior fornix, and then you compress both hands against each other. Is to compress the anterior and the posterior walls to cause a myotampona to reduce the bleeding. If they say that if your bimanual compression works, it means that it's a sign that your compression sutures, because that's the same mechanism that you perform in theater, compression sutures you apply in theater will work. Or so, for example, if you are bringing the patient from a referral facility and you're in an ambulance, the patient is actively bleeding, you can do this bimanual under sterile conditions. You can wear a sterile glove and do this bimanual compression to temporarily stop the bleeding before you get to the referral site. You can also do aortic compression where you can put your fist on the umbilicus and then gently palpate downwards around the aorta. It is said to compress the aorta to reduce the supply to the uterines and then the uterus as well. There's also the non-pneumatic anti-shock garment that can be given. It's also a temporal garment that is worn. I have not seen one before, but there are indications with which that I have a picture here. Okay. So it reverses hypovolemic shock by returning blood to vital organs, and then it slows blood flow to lower body and decreases bleeding. So that's the main mechanism. There are some indications as to whether to use it. So usually in a referral facility, when they say that when the ABL is greater than 500 mils and where you have a systolic blood pressure of less than 100 millimeters of mercury and a pulse greater than 100, you can use this garment if it's available. Sorry. So some of the things I've already mentioned, so I'll just go through a bit fast. So this is the condom tamponade, balloon tamponade that we usually use. You have a Foley's catheter attached to the male condom. Sorry, the male condom, yes, of course. And then you insert it by using a speculum into the uterus, and then you inflate it to cause a tamponade effect. There are other tubes that can be used, but they are not readily available where we are. So this is a picture of the bimanual uterine compression. Okay. This is so this is also for the refractory PPH if all your initial measures have failed. So this is done in theater where you apply brace sutures anteriorly and posteriorly to the uterus, and then you tie it to help to cause a tamponade effect to reduce bleeding. These are other surgical management for the PPH. So the uterine arteries can be ligated. The bilateral, there can be internal artery ligation also done. You can also have peripartum hysterectomy done if all these fails, but of course, it comes with complications. So you can have a lot of, remember I mentioned that more than 300 liters is the amount for diagnosing PPH with cesarean hysterectomy elective. So there will be a lot of blood transfusions that have to be done with all its complications because you have more blood loss from it. You can have injury to the surrounding organs. Retained placenta, I think I already mentioned, but usually if from your history there is retained placenta, you need to, you would give your oxytocin. Sometimes you can repeat the bolus that is given, and then you attempt to do the controlled cord traction. And you can also give intraumbilical oxytocin injection. If all that fails, you need to move to theater under anesthesia to gently remove, tracing the cord from the center to get to the edges of the placenta, and then wholly with your hand, bring the placenta out with your non-dominant hand on the uterus to prevent a uterine inversion sometimes. So I'll provide the slides we provided so we can read. This is a picture showing cervical lacerations. When they are tears, you need to repair them. Frequently, they happen around the 3 and the 9 o'clock. That is where you have the uterine vessels entering the cervix to the rest of the uterus, the ascending and then descending branches. So usually you have tears around that place. So you need to properly diagnose it, and then under good light source and good anesthesia, you can repair. There are complications that are usually associated with it. And then, okay, I think I've already. You can also have broad ligament hematoma, which you would need to take the patient to theater, and then sometimes the ligament and the hematoma is evacuated. Laparotomy is done for the hematoma to be evacuated, and then there's ligation of the arteries. Uterine rupture can also be a cause of the PPH, incomplete or complete, and they can all come with their complications, and then you need to repair in theater as well. Coagulopathy, which is the thrombin, I think I already mentioned the causes. They will usually present with some physical manifestations such as purpura, ecchymosis, etc. So your laboratory findings is very important. That's why when you take your sample, you can do a clotting profile, and then also even your bedside, and then sometimes your physical examination or your history can give you a clue to this. So with the management of that one, you would have to give your tranexamic acid, vitamin K, recombinant, activated factor 8, other clotting factors if they are available to help. Acute uterine inversion, which is the last of the 4 etiologies, the 4 T's plus the uterine inversion. And this usually happens when there's collapse of the fundus of the uterine cavity. It is quite rare, and it's a complication of poor management of the 3rd stage. The causes are usually from a short cord, or sometimes when fundal pressure is not well applied. So you have the fundus of the uterus falling into the cervix and to the vagina and then out. And morbidly adherent placenta could also be a cause of it. These are pictures showing it. The management is either by manual reduction, hydrostatic reduction, or sometimes surgical. You have to take the patient to theater to return the uterus to its original shape. They can present with very brisk bleeding, and it can be quite severe and fatal. So how do we prevent primary PPH? Primary PPH can be prevented antenatally, and then intrapartum, and then also immediate postpartum. So antenatally, we have from our antenatal clinic, I forgot to mention that one of the risk factors, aggravating risk factors for PPH is anemia. So antenatally, the woman's HB has to be optimized, whether she, in terms of nutrition-wise, or she being kept on the hematinics and then followed up to be sure that because once the HB is low, the least amount of blood, there'll be hemodynamic instability. So you want to ensure that her hemoglobin is optimal before she goes into labor. And high-risk individuals, all that I mentioned, multiparity, all the causes that cause hyperdistension of the uterus, low-lying placenta, they can all be picked up via ultrasound scan in the antenatal period, and they should be picked up and followed through. And their treatment, their management, or their delivery should be done at facilities that have the resources and the right equipment, and then the measures in place to be able to control the postpartum hemorrhage if it occurs. Intrapartum-wise, it can be prevented if the active management of the third stage is done. And it's been shown that it reduces the primary postpartum by about 60%. And also minimizing the 3 delays, of course, is one of the main things that would help us to reduce PPH. That's the delay in the patient deciding to seek healthcare, also delay in transportation, the lack of ambulance or functional vehicles available to be able to transport these women. And also when they get to the health facility, delay in receiving the needed and then the expect care that they need. These are some recommendations from FIGO. It's quite lengthy, so when you get the slides, you can read. Complications of primary PPH include early and late. Early, you can have hypovolemic shock, cerebral anoxia, hypoxia, then renal failure, acute renal failure, which can subsequently lead to chronic renal failure and death, which is a big deal when it comes to PPH in the low-income countries. Late anemia, with all its complications that can result from it, the heart failures that can arise from it, and all the other complications. Transfusion-related infections, because you would have to transfuse the woman once you have the PPH, and then she would need blood transfusion. Puerperal sepsis can come because of all the manipulations that the tears and then the repairs manipulations that are involved. You can have thromboembolism from PPH, Sheehan syndrome, anterior pituitary necrosis, which can subsequently lead to infertility later. So in conclusion, primary PPH is a serious life-threatening obstetric emergency, and early recognition of this condition results in better outcomes. Stimulation training on how to manage PPH, especially the emotive, is encouraged or should be encouraged, and each hospital should have a protocol on the management of PPH. The evidence-based prevention and management of PPH can be achieved with the use of relatively inexpensive drugs, and women should be monitored closely during the first hour after delivery of the baby and placenta, and accurate blood loss measurement should be implemented. These are my references. Thank you.
Thank you so much, Dr. Donnee, for an excellent job done. We are grateful that you'll be able to do this in less than an hour, so it allows us some time to be able to take some questions. Dr. Hawa, I don't know if you have some comments before we take the questions.
Oh, I think that Donnee has done justice to the topic. It's a very huge topic. The facets of it tells you, and each T has so many things under it, but I think she has done a good job trying to summarize everything for us in less than an hour. So let's hear the questions so that we would give people the information they need, not what we think they want.
Fantastic. Thanks. So if you have any question, kindly electronically put up your hand. I will mute you to ask your question. Thank you. Whilst we wait for questions from the participants, if you check in the chat box, like Dr. Donnee mentioned, the slides will be made available, and the recording as well will be put on the YouTube channel. So I've just shared some information in there that you can subscribe to. You have the slides, you have the recording, and then as and when you want to access it, it's all yours. We try to serve you the way you want. So kindly electronically put up your hand if you want to ask a question. Nicola, please go ahead. I've asked you to unmute yourself.
Okay, good evening. Doctors, I want to find out concerning the management, specifically the oxytocin, the one that you inculcate in the normal saline. You made mention of initially you will inculcate 10 international units and run it within 10 minutes. Then 2 hours time, you inculcate 20 international units and run it for the 4 hours ahead. But I want to find which one works effectively, because per our hospital, we normally use either 20 or 30 international units inculcated in 500 ml of normal saline, and it is being regulated within 16 per minute drop. I wanted to find out which one works effectively to prevent the PPH. Thank you.
Okay, thank you. So I was saying that after giving the IV IM bolus, we give 10 international. So if it's PPH, between 20 to 40, you can even give as much as 40 international units in the 500 mils to run within 2 to 4 hours. But sometimes it's not done that way. So you usually run it very fast, and then after that, because the point is to sustain the uterus to be in that contracted state. But the emotive now is saying that you would give, after you have given your IM, you give the 10 international units in the 500 mils to run for 10 minutes. So you ensure that it's run for 10 minutes. Then you can now give 20 in 1 liter to run for a period of 4 hours. So that's, I don't know if Dr. Hawa has anything to add, but
yeah. So I think you've explained it right. So what you do initially, you have given maybe 10 international units to do your 3rd stage. That is not counted. When the PPH occurs, you put 10 international units in 500 ml saline, and we say that even to make it go faster, you may want to do 250 ml saline if you have those bags, and then let it run over 10 minutes. After you are done, you now put another 10 in a 500 ml and let it run for 2 hours, and you can repeat another 2 hours. So that makes it 20 in 1 liter. So if you have a 1 liter bag, because the 1 liter IV fluid bags do not come that easily. So you put another 10 in 500 mils and run that one to sustain the uterine contraction over 2 hours. And remember, whilst you are doing this, you are doing other things. You are giving misoprostol, you are squeezing the uterus together, you are checking to see whether there is some tears or the placenta was not fully delivered and there are some retained membranes or lobes, and then you do the definitive management, and that should stop the bleeding. So for the oxytocin, it is not after. You have to give it immediately after you've given your 10. The other one that is continuing for 2 hours starts immediately. You don't wait for 2 hours before you give it. I hope it's clear.
Great.
Thank you, Bob.
Yeah, so we'll take the questions in the chat box because I don't see any hand up. There are a couple of them. I'll probably just do about 3 at a go, and then we can address that. Then we'll take the next 3 and then the last 3. So the first one, Mundashiro is asking, what's your comment on what could possibly account for the increase in maternal mortality from 3.5% in 2022 to 14% in 2023 at the Tamale Teaching Hospital? Yeah, then the second one from Mudashiro again, in the correction of shock in PPH, is the administration of calcium gluconate after 5 units of blood transfusion optional? And what role does it play? And then the last one is, please, how much from Jerry? Please, how much oxytocin do you start with for the atony and the maximum amount you can give? So these are like the first 3.
Donnee, I think you should. We've answered the third one. The third one. The third one has been answered, and the question about mortality in TTH is multifactorial. And I really don't think that maternity service agenda is about dissecting issues of TTH. So I wouldn't want to go there. But most often, if you look at the kind of deaths we record in TTH, PPH is not the #1 cause of mortality. It is hypertensive disorders and sickle cell disease. They are the leading causes of our mortality. So I'll leave it as that, and I would not go further.
Great.
Okay.
The third one was on the calcium gluconate after 5
Okay,
minutes.
And
so
then
the
for the calcium,
calcium
okay,
gluconate.
all right, go ahead.
So the calcium gluconate, a lot of blood transfusion causes a lot of citrate to be released, and they said this citrate sometimes can it binds to calcium and can cause hypocalcemia. So that's actually the main reason. It would lead to hypocalcemia. So the calcium gluconate binds to the citrate to counteract that effect, most likely with multiple blood transfusion.
Is it an optional thing to give after 5 minutes?
It's not
Or-
optional. It depends on how fast you did the transfusion. So there are times that we realize that the woman has massive PPH and you have to give massive blood transfusion. There's a technical definition for massive blood transfusion. So you have a woman bleeding heavily, you've transfused the 3-4 units as a go. The calcium citrate is used to process the blood, to keep it non-clotting whilst it's lying in the blood bank, and it is in those bags. So if you are giving the woman so much of it at a time, most probably she has bled out all her clotting factors. So she ends up having blood that cannot clot within her, and your PPH will not be resolving. So once you've realized that you've transfused the woman rapidly and massively, you should consider giving the calcium gluconate so that things can reverse for you to have the blood clotting. So it's not optional, but people should be conscious of it. Most often we forget and we keep pushing in the blood and the trickling keeps going on because there is some now, it didn't start with coagulopathy, but now there is coagulopathy contributed to by the massive transfusion.
Great. From a physician point of view, we're also concerned about potassium as well. Most of our blood that is transfused is stored blood. And so definitely potassium would have leaked out of the cells. And so with 5 units, definitely there's a huge concern about hyperkalemia as well, in addition to all that has been explained. The next 3 set of questions as well, I think a couple of them are asking for the slides, which I've already shared in the chat box about how to access them. Just click on those links, and then you have them on the YouTube page as well as the videos. And then I think we've talked about the calcium gluconate presentation on YouTube, answered that. Then please, how do you approach a woman with PPH from previous history of heart failure in terms of the fluid resuscitation? I think this has, in a way, been addressed. It's just about the volume of transfusion. I don't know if you guys have some more to add. And then the next one, I'll take 3 of them so that then we can address. So that's one. The next one is, how is the condom tamponer done? I'm wondering if you'll be able to demonstrate that unless you watch the videos about it, but we'll see what they say. Then, please, in the health center with no theater, aside the bimanual compression and aortic compression and the use of emotive, what else can be used before transfer to a higher facility? So these are the next 3, if you can take those.
I think I mentioned, I'll take the last one. I think I mentioned what can be done before transfer. Apart from the emotive, because if you are following the emotive and then you are identifying the initial evaluation, you're able to assess the blood loss, and then you do your massaging of the uterus, give your tranexamic acid, oxytocin, and then you even identify that there are tears and then the lacerations. And still, it's from 820, you are not having any headway, then you're going to escalate. And by escalating would mean sending the patient to theater. If you're not in a facility that you have a theater available or the skilled personnel to be able to attend to the patient, and you're referring, I mentioned that you can do temporary procedures such as the bimanual compression. You may have to watch videos, but I try to explain it, or the aortic compression. If you're in an ambulance, you can attempt to do, even though it would require quite a lot of effort, but it can temporarily stop the bleeding whilst you are massaging your uterus, giving you oxytocin till you get to your referral facility. That is what I think. I don't know if there's any other thing.
Great. I think we've done about 7 minutes. We allow a question from each of those who have put up their hands, and then we can
So, Dominic,
Dr.
sorry.
Hawa, please go on.
Yeah, so to add to it, the anti-shock garments, some peripheral hospitals have them. Please check in your boxes, in your offices, in charges offices and stuff like that for these things, because they are life-saving. Most often they come and we just pack them down. We don't use them. Then there are videos on YouTube on how to wear a patient the anti-shock garment. If you have the anti-shock garment, it will take away a lot of the bimanual and the pressure that you have to do, because it will squeeze all the muscles from below and push all the blood up, so that at least your patient will remain conscious whilst you transfer to a bigger place.
Great. So let's hear from those whose hands are up, and then kindly keep your question brief because we've gone past the hour mark. Fred, please go ahead. I've asked you to unmute yourself.
So my question is on clarification on the oxytocin. I mean, I'm familiar with protocols where after you've given your 10 units for the third stage for a vaginal delivery, in the room, whilst you do your other maneuvers, you can just give a 5-unit bolus and then go to a 14,500. In the explanation, you said if you need to give an additional oxytocin, you put the initial one in an infusion. Is there any reason why you cannot just give a bolus? Thank you.
Great, thank you. Dr. Hawa, Dr. Dieu-Donnee, any response to this?
Yes, so I think that the bolus system was what we're doing before. A PPH appears, whether or not the third stage has been, the AMSEL had been started and the patient has had a first oxytocin. You can give, you repeat, actually, that's what you say. You repeat another IM or IV oxytocin and continue with it. The oxytocin in IV infusion is the emotive schedule. That's what the study used. And so that putting the next IV, next 10 units oxytocin in 500 ml saline is the emotive schedule. It doesn't make it any different. You can give it, if you're following one protocol, it's best you follow one. Our regular one was that when you do it, when the woman comes in, repeat the oxytocin and continue with the management. And that repeat can be an IM or IV. The IV in normal saline is the emotive protocol. So if you are explaining, you can't change it. You have to explain it as it was in their study. Thank you.
Thank you. Nicola, your hand is still up. Is it a legacy hand or you have another question? I've asked you to unmute yourself.
Yes, I have another question. Please, this is about the misoprostol. Like, we normally, I saw in the presentation from 600 microgram to 800. So I want to know the ideal administration. Some we normally give 200 sublingually, then 600 rectally. So I want to find out the ideal thing to be done. Then lastly, the question is on the balloon tamponade. I want to find out, is it ideal for every client, or we have some specific clients that have allergy to it? Thank you.
Please, I want to answer. I don't know if I understood her question on the balloon tamponade.
Yeah, please go ahead.
Whether some have allergy?
Yes, sister.
Okay. I don't know about that, but it's one of the refractory measures, if you've, after doing your massage, I mean, once you know the course is from 820, doing your massage, and then you what you call give your oxytocin, and still the uterus is not well contracted in theater, is one of the things that you want to do if you've ruled out retained placenta and then trauma and an infection. You would want to pass the condom tamponade, because it also helps with the contraction. It forms like a mild tamponade to be able to stop the bleeding. It goes to rest on the uterine bed, and like what the muscles will usually do to ligate or compress on the vessels, that is what it will do. So I don't know, unless the person has specific allergies to latex or something. I maybe
Yeah,
if Dr. Hawa can help.
yeah, to come in, let me just come in. The best to use, there are actually proper devices, and during the presentation, Dr. Donnee mentioned them, that have been designed to be used to do this tamponade. Condom tamponade is a makeshift one that we do in low resource countries like Ghana, because we don't have these sophisticated devices. And these sophisticated devices are made of very low allergenic material that will not cause reactions. But here we don't have them. And you have a woman bleeding. You may not at that point know whether she's allergic to latex, which is the commonest condom we have. But would you want to wait on that and then lose the woman? I will still put in the condom tamponade and then hope that her allergic reaction is something that we can manage. So it's a very difficult question to answer. But then until you put the condom in there, you may not have an idea that the woman has a reaction. If she's able to tell you that, no, I cannot have a condom placed in it because I react to condom, but at that moment that the woman is bleeding, probably unconscious, it may be difficult to get that fact. So let's put it and save the life. Now, the issue about the cytotech, 600 to 800 microgram, you can give the whole thing either rectally or sublingually, but then we prefer the rectal route because, yes, the patient may be a little semi-conscious, agitated and all that. You don't want her to aspirate on anything that you're going to put in the patient's mouth. But when it's a normal labor, you are preventing PPH, there is no PPH ongoing, the woman is stable and all that, you can put the cytotech sublingual and it's fine. It even acts faster than the rectal route.
Okay, thank you, sister.
All right. You're welcome, sister. Yeah, so
You're
let's
welcome.
I don't see any hand up. If your question hasn't been answered in the chat box, probably for just a minute, you can put up your hand electronically and I'll let you talk and then we can close because we've gone 15 minutes beyond the 4 o'clock mark. Usually we don't want to keep people much waiting. Yeah, so I see Rafi, your hand is up. I've asked you to unmute yourself. Please go ahead. We won't be able to take any more questions after hers and we'll share the slides, we'll share the video in the YouTube channel that I've posted in the chat box. Rafia, please go ahead.
Yeah. Good evening, Doc. I've really
evening.
enjoyed the presentation. Please, during the presentation, you spoke about prompt and effective resuscitation, and you mentioned about administration of 1 gram of tranexamic acid over 10 minutes. Yes. Please, I want to know, is it a standard protocol? Because what I'm asking, our place, mostly our facility, we do give 2 grams. So I don't know if we are really doing the right thing or not. So I want to know whether is it a 2 gram, as you said, or sorry, as you said, 1 gram. But our place, we do give 2 grams over 10 to 15 minutes. Then we repeat after 30 to 40 minutes. So please, I want you to clarify on that. Thank you.
Okay, so I'm actually, my information is from the emotive bundle, but even prior to the emotive, is 1 gram that is in the literature. You can repeat another gram after 30 minutes. But in the emotive, you give the 1 gram over 10 minutes. And then
Okay.
you may or may not repeat another
Okay.
gram, but it's 1 gram that is given.
Okay. Thank you.
Great. So thank you so much, Dr. Donnee. Thank you, Dr. Hawa, for leading us with this presentation. And thanks to everyone who joined us today for the presentation. Like we mentioned, coming Thursday and Friday, same time, same link, same login details. You can hook in for an hour to learn a thing or two. If you like our pages on Facebook and on LinkedIn, you'll be able to see the various topics as we put them up. And then if you subscribe to our YouTube channel as well, you'll find that this recording will be made available. All the other recordings of the previous presentations have been put up, so you can access that. Last week we did cardiac arrest, that has been put up. We've done asthma in pregnancy, that has been put up. We've done bronchial asthma in the adult population, that has been put up. And a couple of all the topics we did last year. So the information is available to you. The PowerPoint presentation slides have also been added to that. And so it's all in your hands. Let's help to educate each other to make the world a better place. Dr. Howe, I don't know if you have any closing remarks, and then we can log out. Thank you so much.
Oh, thank you so much, Dominic, and thank you to everyone who stayed on to the end. I hope we have learned a thing or two, and let's all be here again next week for some more. Have a nice weekend to all.
Thank you. Bye-bye. Thank you, Dr. Donnee. Legend.